recorded and put on YouTube later. So enjoy.
Perfect, thank you. All right, hi everyone. I'm Natalie. I'm a third year and I was placed at the School of Clinical Sciences this year and at Casey specifically. So maybe you guys might end up there next year, hopefully. And yeah, all I really got to do was Gen Surg rotation. So if anyone has any questions about that or like med in general or how year 3 works, yeah, feel free to send me a message, or about haematology, obviously, email or Facebook at Natalie Elizabeth. So yeah, so I'm not sure if this has changed for you this year. It might be, but I've got the yield in just in case. And this is what we'll be covering. So right from the basics up to some of the trickier things like the hematological malignancies can be a bit tricky sometimes. And I've got some good resources here that I got some things from as well. Also, I've got some pictures throughout, and sometimes they're the same thing, but sometimes having different pictures and different kind of perspectives helps. So I hope it helps. And I've also got some questions and all the answers are in the notes section. So I don't have to worry about that. These are just some like buzzwords, but we won't worry about that. That's just in there if required. So let's just start with the basics. And I'll kind of go relatively quickly through this. So just move this. Okay, so hematopoiesis is basically the differentiation process where your cells from your stem cells creates all your actual like red blood cells, white blood cells, platelets, all those kinds of things. And the differentiation involves some like cytokines and growth factors and things like that. And also some helpers, which is really important when we talk about anemia. So like iron, B12 and folic acid. And it's also really good to know just that the medullary hematopoiesis is occurring in your pelvis, sternum and vertebra bone marrow, and your extramedullary is anything outside of the bone marrow. So liver, spleen and thymus, and spleen is particularly important when we talk about a few disorders, particularly like thalassemia and things. So keep in mind the spleen. And here is just a good diagram of actually what is occurring. So you've got your myeloid and your lymphoid progenitors. And easy way to remember is that lymphoid leads to lymphoblast, which leads to lymphocyte. So kind of like the words make sense, and everything else that's not a lymphoid cell or like a lymphocyte or a plasma cell is going to be myeloid. So it's not too difficult to remember, but it is important when we come to the malignancies and myeloproliferative conditions and things like that. These are just what the cells look like on the blood film, but yeah, we won't obviously go through each one. So just again, basics, because this is going to help us with anemia. We'll start with red blood cells. So as you would know, they're regulated by EPO release from the kidneys. So that's why people with kidney problems often have issues with anemia as well. And they don't have a nuclei. So if you see red blood cells that have a nuclei, you know the body is trying to pump them out really quickly, but not very well. They have a 120-day lifespan, so you guys would probably know that from your HbA1c tests that you do in diabetics to check their control. They're used for oxygen delivery, and these different types are really important when we talk about hemoglobinopathies. So just keep those in mind. And then you've got your platelets, which we'll talk about as well with some of the disorders later. But again, they're also destroyed in the spleen, which is important, and they're involved in your platelet plugs and then clots, so they're quite important as well. Okay, so we're going to move on to anemia, which is a really core topic. And I want to stress that this presentation is really mainly about the core things. There's a few, I guess, less core, but mainly core things, because I think otherwise you can get very confused. So let's start with the hemoglobin molecule. Really basic, but it's good to understand. So you have 4 chains in your hemoglobin molecule, and you have in each chain a heme site. And each heme site binds iron. That's why iron's so important. And then your oxygen binds to each iron. So that's how oxygen is incorporated into the hemoglobin molecule. And obviously then you have heaps of hemoglobin molecules per red blood cell, and you've got heaps of red blood cells. So you've got a lot of oxygen delivery going on. So in terms of the definition, anemia is just when you have decreased numbers of red blood cells or hemoglobin. And whatever the cause, as you'll see, there's a lot of causes, it just results in there being decreased oxygen carrying capacity to the tissues. Okay, so this is like a bit of a segue into the anemia types, and it's actually kind of a good skill to have, because basically you're going to be ordering FBEs or blood counts or examinations all the time. So I guess I'll just go through the steps of how to do it, because it's really useful to be able to do. So first step is to look at your hemoglobin, obviously, because that's going to tell you if you have anemia. So if it's low, then you have anemia, like pretty easy. And you've got some, if they don't give you ranges, but they should, here are the ranges for male and female. So you should have more than 130 and more than 115. Then you want to classify the type of anemia. So you've worked out it's anemia. Now you want to know, okay, is it microcytic, normocytic, or macrocytic? So you do that by looking at your mean cell volume, which is basically like the size. So if it's low, it's microcytic. If it's normal, it's normocytic. And if it's high, it's macrocytic. Pretty self-explanatory. You can then just check out if you want, if it happens to be hypochromic, but it's not really a key step. You don't really need to know that as much. What is more important is your reticulocytes. So that's your immature red blood cells. So obviously, if they're normal, within normal range, then it's normal. Or if you have a normocytic anemia, which you've already worked out, then consider a chronic kidney disease or an aplastic anemia, because the body isn't actually able to produce more red blood cells in response to the anemia. So there's obviously an issue there, either in the kidneys or the bone marrow. But if you are actually responding to the anemia and producing more red blood cells to compensate, then you're either hemolyzing your red blood cells or you've got some blood loss going on. So hopefully that makes sense. This is what you do once you've kind of interpreted your blood count. So you've worked out if it's microcytic, normocytic, or macrocytic, and then you can work out, you don't really have to worry about all these tests except probably reticulocytes and if you've got a megaloblastic change, but then you can work out what the cause could be. So TAILS is really the only acronym that I use for microcytic for the causes. So thalassemia, anemia of chronic disease, iron deficiency, and then you've got lead and sideroblastic, which, yeah, if anyone ever asks you the cause of microcytic anemia, don't come straight out with lead poisoning, because they're going to be like, you should say iron deficiency anemia first rather than that. And then normocytic, we've kind of gone through it, but you've got your chronic kidney disease, aplastic anemia, which is just failure of your bone marrow, blood loss, and if you've got some sort of hemolytic anemia going on. And then macrocytic, you separate it into megaloblastic, which just means hypersegmented neutrophils. And if you've got them, it's either folate, B12, or like a drug that's causing folate or B12 deficiency, or it's one of these other causes, which, yeah, basically everything else is no megaloblastic changes. So yeah, this is really core stuff that I would recommend knowing. This is just like another version in case that helps. It's also got your signs of hemolysis here as well. And this is like another version if you want to know like everything in like kind of a diagrammatic format from causes to management. But yeah, don't feel like you need to know all of this. It's just if you wanted the bigger picture. So here are some questions. I don't really know how this is going to operate on Zoom, but I guess I can give you a bit of time to maybe have a go at this question here in the corner. I feel like that's a pretty good one. And yeah, maybe I'll give you like 10 seconds to have a go, write down a response, and then we'll talk about it. So hopefully that was enough time. So basically, we know it's a microcytic blood film. So that means that we can knock out anything that's not microcytic. So folate we know is macrocytic, B12 we know is macrocytic, so is hypothyroidism, so is alcohol use. So it's an iron deficiency anemia. I feel like this question isn't as important, so we don't have to do that. This one I'll just quickly go over. So key points is that I'll just skip straight to, which is that we've got hypersegmented neutrophils, which means it's a megaloblastic anemia. And it's we know that because there's also an increased MCV. And then the answer here is pernicious anemia because that causes a B12 deficiency. If you're not sure exactly the mechanism, it's basically where you have antibodies against your intrinsic factor, which, as you know, is required for B12 absorption. This one I will stress because I got totally roasted with this. So if you have a patient with a B12 deficiency, that can then cause folate deficiency because you actually need B12 to help with your folate absorption. So if you have this situation where you have both, the question I got was, do you supplement folic acid or B12 first? And I had a 50-50 chance of getting it right, and I got it wrong, which was great in front of everybody. So to avoid this, I'll just tell you the answer. It's B12, because if you don't do your B12 first, then you actually exacerbate your neuropathy that you get. So hopefully that's just a handy tip. So moving straight along, these are just your general anemia symptoms, risk factors, what you might get on examination and management. So that's just a general thing, which I feel will serve you very well. But we might skip straight into the general conditions. So this is, again, just some diagrams about how iron is regulated and the difference between your iron from animal products and plant-based products. But again, I'm going to skip straight to actually interpreting iron studies and going into it a bit more. So basically, again, we've got a bit of a process. We first have to look pretty obviously at iron. So we look at the iron, and if it's low, it's likely you're iron deficient, but it's not the best indicator. You actually want to go to your ferritin. So your ferritin is your iron storage. So it's kind of like, we had this analogy where your iron is like someone's wallet. So you can kind of get an indicator, but you actually want to look at their bank account to kind of calculate their net worth. So ferritin's like your bank account. So if that's low, likely you're iron deficient because you don't have enough to store. If it's high, you likely have inflammation, possibly because it's actually an acute phase reactant, or hemochromatosis, which is like a condition where you get iron overload if it's super, super high. Then you look at your transferrin, which is your iron transport molecule. So if that is high, it's likely you're iron deficient because the body's trying to like transport all this non-existent iron around. And so that's another indicator for iron deficiency. And then if your total iron binding capacity is high, then you're also likely to be iron deficient because the transferrin really wants to like bind all this iron to send it everywhere. but there's actually none there to bind. So that's just a little step-by-step as to how to do that. So let's actually move on to some questions, again, which will tell us a little bit about some more causes. So I might have a go at this one here. So I'll just summarize the key points with this. So kind of a weird way to put it, but you have got a young boy who's Arabic, and he has splenomegaly and jaundice. So already you're probably thinking, oh, there's been some breakdown of red blood cells causing the jaundice. We've got a microcytic hypochromic anemia, and fetal hemoglobin accounts for most of the hemoglobin. So this is where you're thinking back to the different types, and you really should have switched by now to your adult hemoglobin. So there's obviously a problem going on. We look at the blood smear, but we don't really even need to as much. We probably already know it's thalassemia based on the fact that this is a child who is of, you can either be of like Mediterranean or Middle Eastern background often for thalassemia, beta thalassemia. And you often have jaundice because in thalassemia, as we'll talk about, you have an issue in your beta chain, which causes instability and lysing of your red blood cells. And we know it's a cause of microcytic anemia. So that's the answer for that one. And then this one you can kind of get based on the fact that it's an African-American man. We've got some chest pain, so there's some issues going on there, which I'll explain when we talk about this condition. But the answer here is sickle cells. And again, it'll become clear when we talk about it. So we'll talk about thalassemia first. So basically, it's really good, as I said, to understand what's going on with your hemoglobin types. So thalassemia is where you've got this mutation in your beta chain. So if we look at your adult hemoglobin, you've got your HbA, which is composed of 2 alpha and 2 beta, and HbA2, which you've got 2 alpha and 2 delta. So you've got 98% is this one here. And this is the one where you have the issue in thalassemia, which is why it's kind of pretty bad. So if you have beta thalassemia major, you have 2 gene deletions, which obviously is kind of bad because you really need this hemoglobin to be operating. And you need transfusions. And often the symptoms present when you have that switch from fetal to adult hemoglobin. And then beta thalassemia minor is when you have just 1 gene deletion, and usually you're asymptomatic because this one here can kind of compensate for it. And then on your blood smear, you'll have these findings here. So you can kind of use that mnemonic if you like, and if it helps. And so I don't kind of bore everybody with going through everything in huge amounts of detail. I've put like a summary table for microcytic. I've left out lead poisoning and sideroblastic because it's not really that important. But here it just goes through like in a little bit more detail if you'd like, exactly what's going on with each of these causes. And we've also got blood smears for them and how you would treat. But I feel like management isn't much of a big thing in year 2. This is the same thing for normocytic. So I'll just briefly talk about sickle cell because we had a question about that. So with sickle cell, it's an autosomal recessive point mutation in your beta chain. And the problem is that you get this weird HBS, which is kind of bad because in conditions of stress, such as like infection or things like that, the cells become really sickled. And if the trigger reverses, then you're fine. But if there's like a lag, then these sickled cells are really good at actually blocking your vessels and causing some complications such as stroke and heart attacks and lots of issues like that. So usually you'll have somebody who will present with those end organ complications with that. And then I'll also quickly mention G6PD. So that's like an X-linked condition. And again, it's a hemolytic condition because the red blood cells are more prone to stresses. And basically, if you get a question which is about like a young boy who has Carver beans and then gets jaundiced and has bite and blister cells, it's like this condition. I kind of think of it as like Carver beans and like Heinz beans, and then like bite the beans. Like it's all like about beans. I feel like you can kind of remember it like that if you'd like to. And this one, don't worry about as much, but I've popped in autoimmune there in case it comes up for some reason. And that's more about the blood films for each. And this is just a diagram showing the occlusion that I was talking about, so you can kind of visualize it a bit more in sickle cell. And this is just a quick thing because sometimes they like to talk about this. So the difference between an indirect and a direct Coombs. So a direct Coombs is basically where you're checking for like some sort of hemolytic anemia due to antibodies in your red blood cells. So if you add your Coombs reagent, it'll show up that you've got those antibodies there causing some sort of hemolytic anemia. But your indirect Coombs is more to do with your blood typing and rhesus. So that's just the difference there, which can be useful to know. And here's just the table. I know it's quite small, but like you can zoom up on it if you like to see it a bit clearer. But your main two megaloblastic macrocytics, I've just popped in there and highlighted the main things like complications such as peripheral neuropathy for B12 and neural tube defects for folate. And popped in that the blood smears are kind of the same for both, so don't really need to worry as much about that. So I'm going to move on to clotting and bleeding disorders. So to understand this, you obviously need to know a little bit about how it all operates. So hemostasis is that balance between your bleeding and your clotting. It's kind of like one continuum. And I kind of have like a very basic diagram of the process. So basically, if you have some sort of damage to your endothelial cells lining your blood vessels, it exposes these really thrombogenic substances that go into your lumen, and they can kind of, the platelets adhere to them and they become activated, and then your whole platelet plug process begins, which then activates your coagulation cascade, which you would know about with your coagulation factors. And then to end that is your fibrinolysis, so your clot breakdown. And I've just drawn an arrow and highlighted D-dimer here because this is a really good indicator, which we'll talk about later on, of whether someone might be clotting, which sounds weird because it's like, isn't it clot breakdown? But it's because the body realizes there's a clot and it tries to break it down. So it actually is an indicator that someone is clotting, even though it's a product of clot breakdown, if that makes sense. Okay, so this is something that will come up in your pharmacology as well with heme. So it's just really important to understand the difference in the clotting pathways for your coagulation. So really simply, your intrinsic is measured by your APTT, and a mnemonic, I guess, that we were told was you play table tennis inside, so TT for table tennis. And then your extrinsic is mainly factor 7, it's testing, and that is prothrombin time, or INR. The terms are kind of interchangeable. So I've got a little bit of info here about if you order coagulation studies, what that involves and what you're testing. So basically, main things to remember is that warfarin is actually, you measure it using your PT, and your heparin is measured using your APTT, and that can come up in questions. And if you want to, it's definitely useful for year 3, but I'm not sure as much for year 2. Might be nice to know about mixing studies and whether things normalize or not with mixing studies, but I won't go into it because, yeah, it takes a little bit to explain. So I'll give you a chance to try maybe this question here at the top. And so I guess a little bit tricky, but I'll give you like a few seconds to have a go at it. Okay, so hopefully that was enough time. Probably wasn't, but this is leading into Virchow's triad. So bit of a segue. So the key here is to recognize that tamoxifen, it's kind of hard if you don't know what it is, but it's a selective estrogen receptor modulator. Basically, it is an estrogen medication, and estrogen, like if it was in the oral contraceptive pill or HRT, hormonal replacement therapy, it's actually pro-thrombotic. So that was just a little thing there. And this question is just testing if you know that the liver produces coagulation factors except for von Willebrand factor. So that's the answer here, a deficiency of all clotting factors except for von Willebrand. And we're going to come to this question in a second, so don't worry about that. So yes, this is the triad I was referring to. You probably have had this talked about a lot. So you've got your hypercoagulability is one part of causing clotting. So big ones here that I want to emphasize are malignancy, estrogen therapy, and obviously if you have a thrombophilia, then you're going to have that. Vascular wall injury is also important. And I think key things are heart valve disease, which makes you very, very liable to form clots, hence why they're often on warfarin, and atherosclerosis as well. And for stasis, atrial fibrillation is the big one. You really need to check if someone should be on anticoagulation therapy if they have atrial fibrillation. And hopefully from your cardio lecture, I think you had today, you probably know why you need that. So we'll move on to DVT and PE. So this is really emphasized in third year as well because it's so important. People can present in so many ways often, and people can forget about this condition. So symptoms. So for a DVT or deep vein thrombosis, here's a little picture. So you usually will present with unilateral, unless you're super unlucky and you have clots in both legs at the same time, but usually just unilateral. Lower leg pain can be often tender in the distribution of the vein. It's swollen, and you can test that by just checking at the tibial tuberosity area if it's swollen compared to the other side, and kind of a dusky red. Then you should always check if it's progressed to a PE. So you can check that by asking if they're short of breath, if they have pleuritic chest pain. Pleuritic just means if they take a deep breath in, does it hurt? Hemoptysis, so coughing up any blood. And often they'll have a low-grade fever, which you can check on their vitals as well. They can have a PE without a DVT as well. So it's not like you have to have a DVT to have a PE or pulmonary embolism. Risk factors are really important. So obviously if they have a history of clots in the legs or lung, if they've traveled recently, which really important to still ask to get in the habit of, but probably not an appropriate question for at the moment exactly. And recent surgery, if they've been bedbound at all, hospitalized. Medications are important if they have a past or present malignancy and blood clotting disorders. Investigations are actually quite complex. There's like an order you need to do. But just simplifying it, it's good to just check for DVT with an ultrasound of the lower limb and checking the Doppler flow of the blood there. You can do a D-dimer, but you've probably heard this is a bit controversial because it's quite sensitive, but a lot of things can cause it, so it's not very specific. So if you get someone's D-dimer and it comes back as being raised, you're kind of stuck because you're already down that road now and you have to keep on investigating because, yeah, it would be remiss not to. But a CT pulmonary angiogram, where you image the lung vessels, is gold standard for PE. And you manage it using anticoagulation, and the length of time for that depends on whether it was a provoked or an unprovoked PE. So you might be on it lifelong, you might be on it for 6 to 12 months. And there's obviously a lot of prevention that you can do to try and avoid this if someone is bedbound. Okay, so moving on to bleeding disorders. Main ones here are hemophilia and I guess von Willebrand's not as key, but liver disease is quite key, but more in the context of chronic liver disease. So here's just a general bleeding history if you suspect someone's got a problem. So yeah, it's really easy, just a top to toe screen of symptoms and like past medical history and things. So it's just there if you require it. Okay, so here are some questions. We won't do this one because we've kind of discussed it. I think we're going to do this one here because it's very topical. So a 4-year-old boy brought to ED, he fell, right knee is really painful. His mother is a carrier of hemophilia A, so it's kind of giving it away. And hemarthrosis, which is bleeding into the joint, is diagnosed and he's investigated for a clotting disorder. So the key here is to recognise that hemophilia A is a factor VIII deficiency. It's X-linked recessive, which makes sense with this. So if it's a factor VIII, we have to think, okay, well, what's going to be affected there? So APTT is obviously going to be affected, so the intrinsic pathway. So that's going to be increased because it's going to take him longer to clot if he doesn't have this factor. And bleeding time is simply asking, are his platelets affected? And they're not, because this is a factor deficiency, nothing to do with platelets. So it's going to be this one as the answer. And this is kind of a tricky question. I'm just going to highlight, I won't tell you the answer yet, but I'm just going to highlight that here contradictory things are going on. So bleeding time is increased, so this patient is more likely to bleed, but they're also got a positive D dimer, which indicates clotting. So they're both bleeding and clotting. So, and it's also, yeah, so this is, just keep this one in mind, and we're going to talk about what it is, this kind of contradictory kind of thing that's going on. So, but anyway, back to hemophilia. So, as I said, it's an X-linked recessive condition. So look out for like any questions that involve like specify it's a male. It can be factor VIII, factor IX, or 11, but factor VIII is the hemophilia A one. And the body is really good at, I guess, you have to get to less than 1% of your having a deficiency to actually get the severe form of hemophilia. So yes, but the features are bleeding into joints is like a real giveaway, as well as severe bleeding after an injury. And yeah, you've got your investigations and management for that one. And von Willebrand disease is an autosomal condition, and it obviously impairs your platelet plug. And just good to know that von Willebrand factor is actually really important in helping factor VIII performance function. So yes, that's just not much about that condition. And this is just an example of ecchymosis, which is like burst blood vessels and like a lot of bleeding that you might get in hemophilia. Okay, so this is a weird like question that I was talking about before. So when you have low platelets, there can be a number of reasons for this. So this condition actually is both coagulation factors and platelets. So that's a bit confusing, but basically if you have low platelets, there are a number of reasons why, and this is one of the main kind of red flag things. So disseminated intravascular coagulation is what DIC is. And it's where you have uncontrolled both bleeding and clotting because you're consuming your platelets and your coagulation factors inappropriately, which means that you actually clot a lot, but then you don't have the resources when you bleed. So you bleed a lot as well. So that's why you get this weird thing where you have like a raised APTT and PT, but you have a positive D dimer. And you have a few causes, but main ones are sepsis and burns as well. Cool. And on blood smear, you'll have fragments of your red blood cells because they're getting like lysed basically, and these are called schistocytes. Cool. Okay, so I'm moving on now to these really annoying conditions. So, sorry, I'm not sure if you can hear, but my dogs are like barking in the background. So these are all about those myeloid cell lineages. So if you can think back to them, and if you have an overproduction of your red blood cells, then it's this condition called polycythemia rubra vera. Don't really need to know too much, except that often it's given away in questions by having really bad like itching after a warm shower. This one here, essential thrombocytopenia, is basically when you have an overproduction of platelets, but they're not very good. So you still have bleeding basically, even though you have an overproduction. And obviously you'll see heaps of platelets on your blood smear. And then myelofibrosis, again, not very high yield. It's just like lots of proliferation of your myeloid cells such that your bone marrow gets fibrosed, which means if you like try and take a sample from your bone marrow, you probably won't be able to get much. And key thing to remember is these all have a JAK2 mutation. So that's a little clue. And also, if you've forgotten what the myeloid cells are, here's just a reminder, because yeah, it's easy to get confused and forget. Okay, so moving on to blood typing, I'm not really going to talk much about this because it's kind of like you kind of just need to know it yourself. But basically, just to quickly run through it, if you have an A blood type, that means you've got the A antigen on your red blood cell, and you're obviously not going to try and agglutinate with yourself. So you're not going to have like anti-A antibodies or anything. You're going to have anti-B antibodies in your plasma. And that principle works for each of your blood types. And then when you're thinking about transfusing, you have to think about what antibodies are in the patient plasma and what are the surface antigens on the donor red blood cells, and then work out, is that going to conflict or is that going to work out? So I have a few like EGs here, if you're still not sure. And this is just a little summary of some of the issues with like blood transfusions and that kind of thing. And there's a little question there, but again, yeah, it wasn't really very high yield from my memory. So it's there if you want it. So this is the more high yield stuff, and I feel as if it can be a bit confusing. So I've tried to kind of go from the basics, and then once you know the basics, you can kind of then move into the more specific types of each and that kind of thing. So let's start with leukemia. So leukemias are basically when you have the malignant transformation of your blood cells, and that occurs in the bone marrow. So the confusing thing is that sometimes these cells can then spill into the bloodstream. So you're like, where did they come from? Where was it from the node? Was it from the bone marrow? But yeah, it can be a bit confusing when that happens, but that's where the cancerous change occurs in the bone marrow. And you can classify it based on acute and chronic. So acute is if you've got immature cells that have been transformed, and chronic is you've got the mature ones that have been kind of turned rogue, and they're mature in terms of like what they look like, but not in function. So yeah, not technically mature in that sense. And then in terms of, you can also classify it by which lineage has actually done the transformation. So Obviously, if it's your myeloblast side, it's your myeloid. If it's your lymphoid side, it's if it's your lymphocytes and all of that, and the lymphocyte precursors, then it's a lymphoid leukemia. So hopefully the terminology there makes a little bit of sense. So here's again a little reminder of all of the lineages, and this is really helpful, I find, when it actually tells you which cells are implicated in which type of leukemia. So as I was saying, your immature ones, and if they're myeloid, then it's going to be acute myeloid leukemia. If it's more of your mature cells, but it's still myeloid, then it's going to be chronic. If you've got your lymphoid progenitors, then it's acute, and then mature, it's chronic. And then here you've got multiple myeloma, which we'll go over in a bit of detail. And here are your other myeloproliferative ones, which we've already talked about. So for leukemias, I've just again tried to really make it quite simple. So you've got some risk factors that are for developing any type of leukemia. Particular important ones are chemo. That can predispose you to it, as well as infections. And then some cluster questions. It's really quite easy if you just think of the cell lines that are affected. So if your red blood cells are being affected and not enough are being produced, then you'll get all of these symptoms of anemia. If your platelets are being kind of overtaken, then you'll get all your platelet kind of bleeding questions. If your white blood cells, yes, they might be increased, but if they are not actually functional, then you'll have fevers and you'll get a lot of infections. You often get hepatosplenomegaly in these kinds of things, and then B symptoms, obviously, as well. Okay, so general investigations. Obviously, you can do a full blood count. You can do a blood smear. Both, you can do like a bone marrow one and like a peripheral blood one, and that can give you some specific clues as to what type of leukemia. And then you've got some more like specialized testing, which isn't as core or anything. And then general treatment. So obviously you've got your chemo. A stem cell transplant is often reserved for those who are fit enough for one. And supportive, so like if they're neutropenic and prone to infections, prophylactic antibiotics, that kind of thing. Okay, so this is a fun little spot diagnosis thing. So basically, I don't know, I'll give you a little go at having a look at them and having a think what they could be. Okay, so this first one, this is a kind of weird looking cell here, and this is the smear cell, and this is basically indicating that this is CLL, so a kind of common adult leukemia. This one is both a peripheral blood smear and an from a bone marrow biopsy, or aspiration, sorry. So most important finding are these stacks of like coins, kind of, which are called rouleaux. So rouleaux, yeah, so this is a multiple myeloma one. We'll skip to this one. So 4, it's pointing at these rods, and these are called like OR rods, and they're found in AML. So that's the one where you've got the 9 and 2 chromosome translocation, and you get that Philadelphia chromosome going on. And then this one is CML. So you've got some myeloid looking cells there. And then this one is ALL. So you can kind of tell that by, they've got like, they kind of look like blueberries. They've got like big blasts that kind of look like lymphocytes. but yeah, it's kind of just recognition, really, is how you learn it. Oh, whoops, I think I said AML was this before, but it's actually CML. So yes, CML is the one actually where you have the translocation. And so I just wanted to, there is a summary table of all of this, but I just wanted to say specifically for CML that this is something which is very treatable, and you treat with tyrosine kinase inhibitors, and you aim to actually get 100% back to normal cells. So hematologists are very proud of this, so it's kind of good to know. And again, I'll show you the summary table in a second for all of those, but we'll quickly move on to lymphoma. So lymphoma is actually when you've got mature lymphocytes are the problem, and the transformation occurs in the lymph nodes and the lymph tissues. So this is why it's a mature thing, because it's outside of the bone marrow. And again, it's confusing because then you can get them spilling into the bloodstream, which is what can happen in leukemia as well. But the key is that the change occurred in the lymph nodes. And then you classify it based on whether there's Reed-Sternberg's or not, and if there's B or T cell lineages or not for non-Hodgkin's, and then if it's low or high grade. So how many cells are turning over is how you classify it with that. And there's no such thing as a myeloid lymphoma, obviously, because you don't have myeloid cells doing things in the lymph nodes. So just something to keep in mind. This is again another reminder of the difference between the two, because this took me so long to understand why they're both in the peripheral blood. But basically, yeah, this is just another reminder. This is a little question about lymphoma. So I'll give you a little chance to have a think about it. Okay, so basically this stands for CMYC, bit of a niche fact, but that's the oncogene that's implicated here. That's 8 and 14, I believe. And this is just a representative of the starry sky that it's talking about. And this is just, showing the jaw lymphadenopathy that often occurs, and you often get a picture of that. And this is completely different. This is hairy cell lymphoma. I just put there as like a spot diagnosis for lymphoma, but it's not Burkitt's or anything. So again, there will be a summary table for all of that, so don't stress. In terms of moving on now to cancer of the plasma cells, so that's multiple myeloma. And I just wanted to emphasize, because it is something that they like to test, exactly the symptoms. So you'll get B symptoms and your CRAB symptoms. So here are your CRAB symptoms. Yeah, it's quite easy, I guess, to remember. Just make sure, that you ask at least one from each of these. And then this is the stack of coins that I was talking about. You can also test for the paraproteins and the immunoglobulins produced by the plasma cells in serum or urine electrophoresis, and you can also check for lytic lesions and pepper pot lesions in like X-rays as well. Okay, so this was the table I was talking about. So basically, it's kind of small, but you can obviously zoom up on it, and it just like has everything at a glance, probably more than you need to know, but it just goes into a bit more detail if you want to know for each specific leukemia, as well as lymphoma. So yes, that is there for your reference. I will just emphasize that this is what the Reed-Sternberg cells actually look like. So yeah, probably good to remember that that's an indicator for Hodgkin's. Anyway, so I'll quickly get through this pharmacology. I think we've still got a little bit of time because we started a little bit later, but I'll quickly go through it. Here's just a little reminder again, because it will help with your understanding. So starting with anticoagulants, So these include heparin, low molecular weight heparin, warfarin, and your DOACs. So really good to understand. So I never understood when someone says heparin, do they mean like low molecular weight or do they just mean heparin? And they mean just the unfractionated heparin. So someone will actually specify like Clexane or something if they're talking about the low molecular weight heparin. So yeah, just a little tip there. In terms of the monitoring, I've got it again here, and I've also got that you give heparin IV as well, and the antidote, which is protamine. Obviously, just in terms of use, your heparins are really good for an acute treatment, particularly like if someone has a heart attack or something like that, you'll often give them, or like a PE, as I was mentioning, you'll give them a heparin. Obviously contraindicated if they're actively bleeding. Warfarin is particularly good for people who have heart valves and issues with that, because the DOACs haven't been proven to help, so you need to put them on warfarin. They're teratogenic, which is important, and you need to bridge them when you first start, because you've still got, it's a vitamin K antagonist, and you've still got some vitamin K hanging around. So if you're really worried about clotting, you should bridge it with a heparin. And the DOACs, I've got them here as well. Easy way to remember what they do is that the ones with X's in their names are the 10A inhibitors. So that's a little trick. Another reminder again, and here are the antiplatelets. So most important, I guess, would be aspirin and clopidogrel. Don't worry about this one as much. These are kind of quite potent and not really used as much. Mainly these, and these are really good again for arterial clots, particularly like if anyone's had like unstable angina or like an NSTEMI or a heart attack, you'll usually pop them on. Well, definitely they should be on aspirin and possibly dual antiplatelet therapy with clopidogrel as well. Thrombolysis is for obviously if someone's having a heart attack and they can't go to the cath lab because they may be in a rural location, or if someone's had a heart attack within 12 hours, you can do that. Or stroke, not hemorrhagic stroke, obviously, ischemic stroke, you can use thrombolysis within the time frame of 4 hours. So we're really nearly done. All I really have is just a quick summary of examination findings. You probably already have that, but you may not have done it in real life given what's been going on. And that's it. So hopefully I didn't go for too long. You're probably quite exhausted because I feel like you guys have been going for so long. But yes, and I didn't even check the chat, so there may have been questions as well, but I hope that helped. And if you have like any questions as well about like anything, yeah, feel free to contact as well.
So thanks so much, Nat. Yeah, good stuff. So tomorrow we just remember we start at 10 again with a couple more revision lectures. So get down to them if you can. And as always, all our revision lecturers are keen to answer questions and stuff. So hit them up if you've got any questions about anything. So thanks very much, guys. See you all tomorrow.